Yes. I can't hear. Yeah, okay. Good morning. Um, can you all hear me? Because I
Yes, sir,
can't
you're
hear.
clear.
Ah, yeah, thank
Yes,
you.
sir,
We can
you're
hear.
clear.
Thank you, thank you. Okay, so next 1 hour, we are going to talk about the end of life care. So it is something not, the topic is not very familiar, I suppose. But it's now it's high time to start this kind of practice also. So we have to know about what is end of life care. And so actually the end of life care we are talking when we are talking about palliative care. uh, is it I'm sharing. Yeah, we are talking. You all can see, no?
Yes, sir, it's
Oh,
full
Yeah.
screen.
yes, sir.
Okay. Now let's talk. Let's start with the WHO definition of palliative care. Maybe you all are aware what is palliative care, but there is a WHO definition. We have to very clearly understand what is palliative care. Now, WHO says palliative care is an approach that improves the quality of life of patients and their families. Now, please make note, palliative care is an approach. It's an approach. For what? To improve the quality of life of patients, not only patients, but their family members. What kind of patients? Patients who are facing the problem associated with life-threatening illnesses. Some places they say life-limiting illnesses. So whoever the patients and their families who are facing the problems due to life-threatening illnesses, then it's an approach to improve their quality of life. How we are going to do this? Through the prevention, very important, through the prevention and release of suffering. So we are going to prevent and we are going to relieve of suffering by means of how? Early identification. So early identification and impeccable assessment. So this word is really important. What do you mean by impeccable assessment? It's a holistic approach. It's a total assessment. You can't miss any part. Okay, it is impeccable assessment. And then the third component comes, it's treatment. So we prevent, then we identify, we assess impeccably, and we treat. What we treat? Mainly the pain and other problems associated with physical, psychosocial, and spiritual. So it's a holistic approach. It's an holistic approach that improves the quality of life of patients, not only patients, but their family members who are facing with problems with associated with life-limiting illnesses or life-threatening illnesses through prevention and relief of suffering of means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So you have to get this definition, permanently in your mind. Otherwise, you are going to, misconduct or miscommunicate or mislead by some other fellows. Palliative care is something else, but palliative care is this is according to the WHO definition. So Palliative care provides relief from pain and other distressing symptoms. For what kind of patients? Patients who are suffering or who are in life-threatening or life-limiting illnesses. Patients with life-threatening or life-limiting illnesses, we provide relief from pain and other distressing symptoms. It affirms life and regards dying as a normal process. So here it is very important. So as a medical professionals, most of the time we think if our patient dies, we think it's somewhere something went wrong. No, it's we our failure. We fail in management or something. So that negative impression comes to our mind as a medical professionals when your patient dies. But palliative care, it says, we are frame life and regards dying as a normal process. So we have to understand everyone of this world is going to die. So we have to take dying as a normal process. Then this is also very important. Palliative care intends neither to hasten or postpone death. We are not hasten or postpone the death. We are dignifyingly, we are allowing to happen a natural death for a patients who are facing in problems with life limiting or life threatening illnesses. And it integrates the psychological and spiritual aspects of patient care. Very important. Psychology and spiritual aspects. Most of the time, when we are treating our patients, we forget about this psychology and the spiritual aspect of patient's care. But in palliative care, there is a big component of psychological and spiritual aspects. It offers a support system to help patients live as actively as possible until their death. So, again, a very important. We offer a support system to what? To help patients live as actively as possible until their death time. It offers a support system to help the family to cope during the patient's illness and in their own bereavement. Very important word. In palliative care, you find this word bereavement. So there will be a bereavement support even after the death of your patient with their loved one, their family members. You have a thing to do with them to give them a good grief support, give them a good bereavement support. So palliative care supports the system. Okay, during patient is alive to their the family members and even after the death of the patient, giving a bereavement support. It uses a team approach to address the needs of patient and their families, including bereavement counseling. So look, it's a team approach. It's a team approach. So again, this word comes, the bereavement counseling will enhance quality of life and may also positively influence the cause of illness. And we are always thinking the quality of life, the dignifying death, and improve the quality of life of patients, not only patients, but their family members also. Is palliative care is applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as now, for example, chemotherapy or radiotherapy, and includes those investigations needed to better understand and manage distressing clinical complications. So, palliative care, we never say there is nothing we can do. So, or we never say, okay, that's it, and now you have to take care of your patients. So, our part is over. No, in palliative care, we never say. There are many things that you can say. Yes, true. Maybe there is no active treatments, okay, but we can always continue some of the treatments. Now, palliative chemotherapy. It's, for example, disseminated ovarian cancer, metastasis breast cancer, or COPD, or the end stage renal failure, or the heart failure, the neurological conditions. There are many, many neurological conditions which needs palliative care. So we can continue some of the, you know, uh, treatments which they have continued, but it's not an active treatment just to maintain. Sometimes chemotherapy, sometimes a radiotherapy. There is a huge component of palliative radiation in oncology care, and there are many, many things. And it doesn't mean that you are doing unnecessary things. No, you can maintain that. It's according to the patient's conditions, but you can give a pain and other symptom reliefs and improve the quality of lives, not only for the patients but their family members, until the patient dies with dignity. So this is what you mean by providing palliative care. It never says when you are, you know, referred to palliative team, that is end of their life, or it is the death certificate, or it's finished. No, nothing doing. So that is why WHO again gave a definition for the end of life care. End of life care. So, end of life care is a supportive care for individuals and their families. So, same thing when palliative care definitions, it's a supportive care. Now, when you are talking about palliative care, it's an approach. So, the end of life care is a part of palliative care, it's a supportive care for individuals and their families facing the end of life. So they are in the latter part of their life journey. So the facing the end of life, focusing on managing symptoms, very important. There are many, many symptoms you have to tackle with. So you have to manage the symptoms. Why? To provide the maximum comfort. So you have to addressing physical, emotional, social and spiritual needs. Please remember, end of life, when you are treating a patient who are in end of life, so all four main component of health is really essential. More than a physical, maybe they need the emotional and the social. More than anything, maybe they need the spiritual care. So please remember, so we have to address all four main component of health. It aims to improve quality of life for both the patients and their loved ones. Very important, the end of life care pattern when they are facing the latter part of last part of their life. End of life care involves treatment, so we have to treat, care and support for people who are nearing the end of their life. It's an important part of palliative care. End of life care is a very important part of palliative care. Dying patients are an integral part of the population of general hospitals. Their death must not be considered a failure. I repeat it, death is not a failure. The only failure is if a person's death is not as restful and dignified as possible. Then we are failed. So death is not a failure, but if you cannot make that patient, the person's death respectful or restful or dignified matter, then you are failed. So this is why palliative care and this end of life care is very important. So when you are talking about end of life care, it focuses on quality of life. So end of life care, I am repeating again and again this word quality of life. End of life care emphasize improving the patient's comfort and well-being rather than solely focusing on curing the underlying illnesses. Sometimes we will discuss further. Sometimes some guidelines, you have to just ignore those guidelines when you are treating the treatment of end stage or end of life care patient. For example, diabetes. So we know when we are now the with all the probable the complications of diabetes. Now the kidneys are failed, and the dementia, the neuropathies, everything due to diabetes. The first diagnosis is diabetes, but it's uncontrolled and very complicated diabetes, which falls into palliative care. Then the end of life care, when you are treating, you never put a diabetic diet, or you never restrict eating sugary things like ice cream. Maybe the last days you have to feed with ice cream, so something like that. So you are not focusing on curing the underlying illnesses, but the quality of life and the comfort and the symptom management. Very importantly, a pain management, then breathing difficulties. There are five things we will talk for later, and other symptoms. And you have to you have to first identify or early recognize, early identify and prevent getting these things by medication, by doing a non-pharmacological method as well. Then if there are symptoms arise, you have to manage it. End of life care. And the holistic approach, again, very important. I repeat, it is not only physical component, there are emotional, social, spiritual, and all these interconnections of these aspects are very important. And please don't forget about the family and the caregiver support, because patient with their families and caregivers. So end of life care extends to supporting the patient's family and caregivers, providing practical and emotional assistance. The family counselings, the group counselings, individual counseling. There are many approaches you can approach the family and the loved ones and the primary, secondary, and other caregivers. Then you can get as a team, get the support of them to treat, to maintain, to get the uplift the comfort of the patient. Then individualized care, very important. The specific needs of each patient and their family are considered. And care plans and tailored accordingly. You have to have a care plan. The location of care, very, very important. End of life care can be provided in various settings. As palliative care, it's a institutional care, it's a community-based care, it's a home care. So it can be, the end of life care also can be provided at hospitals, tertiary care or whatever, the hospitals, or it can be in a community level where the hospices and the other uh, community places, then at your home. So all these places you can provide end of care as well. So I'm going to ask a question. Now let me know, please think about your death, your own death. Now you are going to die. Are you agree with me? Every one of is going to die, isn't it?
Yes.
Yes.
Yeah,
So where do you want to die?
At my home.
So
at
you
home.
want to die at your home. Others,
At home, me also.
Better. Yeah, this at
it
once
is
better.
not, yeah, it is not just simply you are doing. We have done many, many, many studies. So we ask these questions globally, nationally, internationally, and 78% of people in this world wanted to die at their own home, at their own room. You know, irrespective of their education, their wealthy, their professional career, their whatever, they want to die at their home. So now the next question comes. In Sri Lanka, in this situation, today's situation, are you comfortable to die at your home? Are you comfortable? Any problems that you refuse die at your home? Or else
Problem with
I'll
the
put it,
supportive care.
yeah, I'll put in this way. No, when your patient wants to die at their own house, are you allowing them to? Or you want to admit?
Depends on the conditions, sir.
No, we are now talking about the last stages. Are you allowing? Most of the time, the Sri Lankan, we have research evidences, Sri Lankan scenario, we are the end of life. Now there is a death rattle. They are grasping. And we are rushing to the tertiary care or a nearby hospital. Is it a true statement or a false statement?
True.
It's
It's
true,
It's
sir.
very
true.
true.
That's
It's
true.
very true. It is day-to-day practice what we are doing. Why we are rushing that patient to the hospital? Why? One is we don't know. There's very, lack of knowledge about palliative care among medical staff, medical professionals. And we don't know about end of life care. And we don't know about our potentials and what we can do, what we cannot do. Number three is there's a guilty feeling. As family members, we think we haven't done much. So to do maximum, we are rushing this patient to when they are grasping, we are rushing to the hospital to do something, isn't it? Isn't it?
Yes, sir.
Yeah, that's
Yeah,
true, sir.
most of the time, practically, that is what's happening. So we think to fulfill our satisfaction, we rush the patient and we never ask patient what is their will, what he or she wants, whether she is comfortable or not. So, if it happens to your father, mother, very immediate family member, as medical officers, we will definitely take them. So, forget about your family members. If something happens to you, your colleague, you are a medical profession. So, we are not allowing anyone to die at our home because we send them to the hospital, maybe the ICU with the connections. In Sri Lankan, ICU admission criteria is what? Mostly connections, isn't it?
Connections.
Relatives. Relatives.
Isn't it? So the Professor Samanna, now he's the Dean of the Faculty, our council member of Feradenia. The professor said 83% of ICU deaths in Sri Lanka are palliative. Now take this statement, 83% of ICU deaths needs palliative care, not ICU care. So can you see the huge, what a cost, the medical, health cost we are losing. We are not identifying this very important component of patient care, the palliative care and end of life care, and we are rushing unnecessarily. These patients, I'm repeating unnecessarily, these patients to the ICU, the top tertiary care hospitals, and we are blocking all the curable beds and maintaining, you know, some end of care support for the patients. Saying that I'm not against the death is a support. Death is a universal thing. Everyone is going to die. But as medical professionals, we have to identify whether they are palliative, whether the active treatment is necessary, whether this patient is in end of life care. For that, we need to have a knowledge, skills to prognosticate what is the probable time of life of these particular patients. Otherwise, we are wasting lot of money, lot of human resources, lot of energy on unnecessary things. By doing that, we are not justifying the patients or the people's wish, because they wish, as we all expend our wishes, we want to die at our house, isn't it? So we have to drastically change this understanding. So timing is very important. So end of life care, normally it's 12 months, a 1 year time, the last 1 year, but it can vary. But the globally we understand it's a 1 year time of your last 12 months of your year, but it can be days, can be weeks, can be months, sometimes little bigger than a year, but it is the timing. So palliative care connection is, I said it's a major part of palliative care. So see the background. This is in I took it from the Canadians. because they are doing Canada and the North American. The expert panel, there's expert panel, Mashison's expert panel on end of life care. So key findings and recommendations. So see, universal agreement. Patients with serious advancing illnesses must A. be reliably informed early on of the full range of options for their care. So are we doing this? We have to inform them early on the full range of options about their care. We have access to and receive care that respects their informed presence. So we have to, they should be access to receive the care that they want, not we want. Okay. Number two, statewide, it is in Americans, quality measures are required. So same approach comes to any other country as well. That is why I took this expert panel. I just wanted to show end of life care is not just a dream. It is happening worldwide. In Sri Lanka, we are trying our level best to implement this. So quality of end of life care. So there are 5 components of quality of end of life care. Number 1 is adequate pain and symptom management. So there is active treatments, active management, particularly in pain management and other symptoms. So don't forget about. Then number 2 is avoiding inappropriate prolongation of dying. So what do you mean by that? Avoiding inappropriate prolongation of dying. You think about it. Then achieving a sense of control, relieving the burden, strengthening relationships with loved ones. Very important, because we have only 1 year if you take, or less than 1 year, maybe few days, few weeks. So strengthening relationships with loved ones also very important. It's our duty to do. So these are the 5 components of quality end of life care. So when does end of life care begin? When? Now you see. So disease is progressing. You can see. So when the disease is progressing, now please concentrate on this thing. Then you will find very clear answer for many questions. So when to start? Can you all see this? Somebody is talking. Did anyone tell something, or can I continue? Hello?
Please continue, sir.
Yeah, okay. So when does end of life care begin? When? Now the disease is progressing, and we can see any active treatment or curative treatment. When you diagnose that, the phase 1 start. Healthy or with reversible illness, some illness, because don't forget, the palliative care patients or end of life care patients, they will not have only one diagnosis. They will have multiple, a packet of diagnoses. So if you take, the cancer, disseminated cancer, there will be pneumonia a few times, some cellulitis, there are renal failures, advanced effects from the allergic effects, some, many skin conditions, many. It's a package of many conditions. So, but disease is progressing. So you have to identify the life limiting, the moment of diagnosis of life limiting, life threatening illness, then the phase 1 starts. The chronic or curative treatments can be continued. Then the phase 2 comes, but you have to start the palliative care from the moment of that diagnosis of a life limiting condition. Not now. For example, when a patient comes with papillary carcinoma of thyroid, comes to your clinic. So you diagnosed, or a breast cancer. So you do a triple assessment. What is triple assessment? You do a clinical breast examination, you do a mammography, radiological findings, plus ultrasound scan of the breast. Now, if you want, you can do MRI, or then you have to histologically prove there are cancer cells. So those what you call the FNAC, true cut biopsy. So you confirm breast cancer. So does it falls to palliative care? No. You have to actively start your treatments to surgery, radiotherapy, chemotherapy, immunotherapy, target therapy. There are many, or a combination. So papillary carcinoma of thyroid also like that. But breast cancer with a progressive thing, even though you are curative, your phases, maybe the patient's conditions, maybe it can falls into a disseminated status. So where the curative part is not going to support you fully. So that time, that is the diagnosis of life-limiting illness. Then you have to start parallel to the chronic and the curative care, the palliative care component. Then the phase 2, early onset chronic condition. Then the phase 3, progressive frequent complications. Then you see, then when the patients come to the phase 3, the curative parts becoming a very low, but the palliative part becoming the component is very much. Then the phase 4, hospice, home, or wherever, the end of life care. So this is, so now you can clearly see when to start the end of life care. Ideal high quality end of life care, if you take patient understand death may be approaching, then now in this phase 2, now here I can tell, now when the moment of diagnosis of life-threatening illnesses, you have to talk to patients and their family members about the advanced care directives. Then when it comes to phase 2, the advanced care directive will continue as advanced care planning. So those are very important component of palliative care. So you have to talk. Now in Sri Lanka, still it is not happening, but the College of Palliative Medicine of Sri Lanka, we have given all the necessary documentation to the legalization procedure to the Ministry of Health Secretary to get the advanced care directives and the advanced care planning component to this country. So we need this. Then if a patient understand, now patients sometimes they say, doctor, I'm going to die. I understand that. So normally it is in phase 3. So here the ideal high quality end of life care should start. And patient understand quality of life trade-offs. Patient's decisions uh, match care delivers from phase 3 to death. Prefer hospice or not hospice. In Sri Lanka, we have only 7 hospices, which are all run by the NGOs, but those are not ideal hospices. They are respite care, they are transition homes, but hospice care also there. So you can refer your patients to all these 7 hospices available in Sri Lanka. And the fourth one is service delivered by skilled professionals to optimize quality of life and patients' physical suffering, psychological suffering, and the family suffering also. This is ideal high quality. So what are the barriers in this thing? Number one is no objective measure or for onset of phase 3. It is clinical practice. It is your knowledge. There is no objective to measure onset of phase 3. But you have to, it is continuous, good relationship with your patients and family members, counseling, family talking, all these things matters to identify the phase 3, and specialization leading to fragmental care, who is responsible, accountable for care from phase 3 to death. So this part is not clear in Sri Lanka, but some other countries it's very clear. That is why the college also came up, and we don't have specialized or consultants, palliative care physicians. We have diplomates only, but gradually these things will happen. But any doctor, if y'all are interested, y'all can treat your patients like this. Okay, so conceptual framework, measuring quality in end of life care, continue. Phase 3. Now we are now talking about, now there are 4 phases. Now we are talking about, now we start end of life care in phase 3, phase 3 and phase 4. Now phase 3, again 2 components. Patient understands prognosis. Sometimes patient themselves understand, most of the time patient themselves understand. Doctor, දැන් අපි මේක කරලා වැඩක් නැහැ. දැන් මං හිතන්නේ මම මැරෙන්න යනවා. So many things. No, please remember the golden time or a golden words of your patients when you are treating your patient. That time is when a patient talks about their own death. Doctor, mama මැරෙයිද? මම මැරෙනවා නේද? Am I going to die? These are the golden words and the golden time of your patient care. Don't miss it. If your patient tells, if your patient willing to talk about their own death, please sit by them and talk, discuss how you want to die, where you want to die, what you can do, what others can do. There are many things. Now we have done again many research, papers has published. It shows probably our medical professions get a more fear than a patient to talk about patient's death. Can you understand? We are not ready. We are not ready to talk about our patient's death in front of them. It is, we have cognitions. We don't want to talk because we are not skilled enough. That is the research finding. So when patient understand about their prognosis is going to go, it is not good. So phase 3 start. Evolution of options. As professionals, you can do the prognostication. Then 3, it is in between phase 3 and phase 4, disease, symptoms, treatments. And phase 4 is actively dying. There is another word, that is terminal care. Terminal care is actively dying, last 24 hours. Actively dying and family experiences. That part goes to the bereavement care. So measuring what matters. The American Academy of Hospice and Palliative Medicine and the Hospice and Palliative Nurses Association, they have developed 12 components to process. Number one is hospice and palliative care, comprehensive assessment within certain time period after admission, any pain treatments, screening for physical symptoms, dyspnea screening and management, discussion of emotional and psychological needs, spiritual religious content, and proportion admitted to hospice for less than 3 days, emergency room visit in last 30 days of life, documentation of surrogate, treatment presence, treatment preference followed, family evaluation of palliative care. So those components are how to measure what matters. So these should integrate our healthcare system. So we know how we are going to die. Are you aware how you are going to die? We have disease trajectories. Only 3 trajectories we have. So which one you want? So this is number 1, short period of evident decline. This is sudden onset of death. So it is MIs, some cancers, accidents, only 10%. Only 10% of patients can die like this suddenly. This is the number 2, trajectory with gradual decline. So your respiratory and heart failure patients dies like this. Then this is the third one, prolonged gradual decline. The dementia, the renal failures, they die. Elderly people, they die like this. So you want to die like this or this, like this. Which one? This is number 1, 2 and 3. This is sudden, this is with a gradual decline, and this is prolonged decline. I think number 1, no?
Sudden.
Sudden. But unfortunately, only Only 10% of this world can achieve this one. Only 10%. 90%, including you and me, we have to die like this or this. That means palliative care is an essential component. Otherwise, we all are going to suffer in our future. Okay? Factors associated with poor prognosis. So if these are, this is our clinical part. So performance status, cachexia syndrome, anorexia, weight loss, dysphagia, xerostomia, delirium or cognitive failure, dyspnea, biological factors, high leukocyte counts, low lymphocyte counts, elevated C-reactive proteins, those are factors associated with poor prognosis. So as a treating physician, you will able to see, okay, this one is not doing good if these factors are associated with your patients. So predictors of end stage illnesses. So generally, what are the predictors? Generally, multiple comorbidities. I said, no, there are packages. Weight loss, greater than 10% weight loss over 6 months. So you have to get some idea. General physical decline. Serum albumin, less than 25 grams per liter. Reducing performance status, ECOG score less than 50%. Dependence in most actively of daily living. So there are dependencies in most of the daily activities of daily living. Cancer, metastasis or not amendable to treatments, performance status, functional ability. So there are many things. There are predictors of end of life stage care. How do you diagnose dying? First, life-limiting illnesses of progressive physical decline, lethargy, deteriorating mobility, limited oral intake or appetite is getting poor and poor, reduced consciousness, minimal response to medical interventions. If you are not sure, please discuss with your colleagues. Rule out reversible causes, very important. You have to treat the treatable. You have to rule out the reversible causes. If you are not sure, please discuss with your colleague. So that is why palliative care is not a one single man's thing. It's a teamwork. It's a multidisciplinary approach. There can be many people can involve to deliver palliative care. Of course, the end of life care. So is dying soon a possibility? Dying soon a possibility. Why is knowing this important? It's very important. You have to know. We can't say, no one can say when we are going to die, but you can prognosticate, you can see, because it's very important for taking decisions on treatments escalations. Consider do not resuscitation things, communication with family, communication within team and palliative care. This is very important in end of life care. You have to truly get to the diagnosis and actively, as soon as possible, you have to actively involve with many components, because you have to decide, you have to talk with your other colleagues about the treatments escalation, about the do not resuscitations considering, not with your colleagues, but the families and the patients, if patients mentally sound. And the communication with family, very important. Now this third one is really important. Most of the time in Sri Lankan scenario, so when the general public comes against medical professionals, mainly due to lack of communications. Are you agree with me or not? Not that we don't have knowledge, not that we don't know how to do it, not that our concern is very poor. No, mainly our communication skills is really poor. Some of our professionals with patients and their family members. Are you agree or not?
Yes, sir, I agree.
Yeah, please remember, if you communicate with your patient, your family members, your problems, 50% your problems over. Now, in this scenario, when you are treating a palliative patient or an end of life care patient, the communication is a very, very important component of your treatment plan. You have to, true communication. Don't tell anything, false things. Don't tell unnecessary informations, means don't exaggerate things or don't undermine things. You have to tell as it is what is happening. And you have to tell your opinion also, but you have to tell the what is normally happens also. Not only depend on your opinion. And please ask what they want. What they want. Ask their concerns also. So, and not only family, not only the patients, you have to have a team, a palliative care team, your colleagues. You have to discuss with them also. Now these are the things I am going to do, these things I am not going to do. So please discuss. So, general principles for end of life care. Review any existing future care plan. If there are any care plans, you have to review it. Communicate with patients where possible, family and other healthcare providers. Review need for hydration and nutrition. This you have to, with your colleagues, you have to talk it. Consider with medical and nursing interventions are appropriate. Review regular medications. Anticipatory prescribing of PRN medication. What is PRN? And frequent assessment. What is PRN? Anyone knows what is PRN?
It's similar to SOS.
Yes, yes. It's a Latin word, sporenata. That means as needed. So SOS. Now, this is very important, very important. Now, I will share one of my recent experience. 93-year-old patient with hypertension for 48 years, with end-stage renal failure, 93 mentally really sound, not dementic. So senile dementia, a few part of senile dementia was present, and many skin manifestations, and fertility, fatigue, all these things present. And he was very concerned about not to do any dialysis. The hemodialysis is refused. So that is patient's autonomy, patient's wish. Okay. When he came, and from the hospital means the private sector, without his concern, but the family members' concern, because of the encephalopathy, uremic encephalopathy, they have done 2 hemodialysis. Patient was in a sedative mood, or the last part not in a, due to encephalopathy, not in a proper situation to concern. So they did 2 hemodialysis and got the blood urea down, got the creatinine also in a good level, and patient was fully aware, means awake, and again deteriorated. And there was a family member, the son, very well learned one. They read about the palliative care and this thing, and they said, no, father is suffering. We don't want this. We want the palliative care. Our father to be, so he's a palliative care, 100% palliative, need a palliative, and the end of life care patient. Then they sent him home. Somehow they got our, numbers and call, and I visited. Then I happened to see him. At the moment also, I am seeing another patient who is having a hepatic failure, end stage liver failure. Now, for this particular patient, the day I went there, he was taking 48 medications. 48, I counted. out of which 8 vitamins, 12 skin, creams, all kind of creams. Can you believe it? 48. So it's very important to diagnose end of life care and review regular medications. Diabetes, you just omit all these lipid lowering, hypoglycemics, all these things. I have treated, I stopped everything. And is there a point of giving vitamins for this kind of patient? He didn't have a proper 2 hours in a day to sleep because every 2 hours somebody puts some pills and put some water. And he refused. I don't want to take. It is patient's autonomy. Sometimes we forget about we are treating patients and they are end of life. They have to end their life. So that is why, particularly the private sector, there is no connectivity. So you treat, somebody treats the heart, somebody treats the kidney, somebody skin, someone mental status, someone something, someone eyes, ear, nose, every orifices you put some medication and finish. And you don't know. But you think you have done your part. But palliative care, it is not like that. It's a holistic approach. In particularly in end of life care, it's a frequent assessment. Please make sure. So assessment of dying patient is you have to prepare, observe for evidence of pain or distress, observe respiratory patterns, examine mouth, very important. Ask about bladder and bowel care. Answer family question outside the room because they can sense. Okay. Symptom management of end of life care. What are the most commonly experienced symptoms in dying patient? There are 5 things. Don't forget about these 5 components. Pain, number one is pain. Any palliative patients, you take 67% of all palliative patients has pain. So you have to assess, you have to measure, and you have to treat. If you are not treating your patient, you are not treating your patient's pain, you are fail. Please remember this. No one should die or live with pain. If somebody says that it hurts, that means he is in pain. So don't argue. You just have to assess, measure, and treat. You have to know what are the WHO pain ladder, and you have to know how to measure the pain scores. There are many scales. So whatever, you have to assess and get the pain score and treat accordingly. Agitation, nausea, vomiting, respiratory tract secretions, and breathlessness. And prescribing principles at the end of life, IV or subcutaneous route is preferable. Please note this, IV or subcutaneous. So if can somebody tell, for a nutrition purpose, for the hydration purposes, can you use subcutaneous route? I'm asking question last 5 minutes.
No, sir.
Can somebody tell?
No, sir. It's near IV.
Can. You can, okay? Please remember, you can give IV fluid subcutaneously, patients with end-of-life care or palliative care. But there are sites. So abdomen to thigh sites, you can give. Per day, you can give 500 cc over 24 hours. Okay? Please remember, you can give subcutaneously. It's a very nice route if you are treating an end-of-life care patient. Okay? You rationalize and prioritize. As I said, 48 into 0. Anticipate symptoms and prescribes PRN medication. Anticipate. Can be pain, can be constipation, can be vomiting, breathlessness, but always seek advice. If any doubt, specialist palliative care advice available. If 24/7, 7 days per week, if it is available, please get their things. So these are the most common symptoms. So pain management is very, very important. So morphine. So how to assess it is PQRST, uh, quality of patient's own word, provoking on words, radiate, severity and time. It's very important. And nausea, vomiting, you can see the statistics here. You have to address and treat. These are the management of nausea and vomiting. You know everything. You can read it. But you have to first assess and you have to know the nausea, vomiting will be. And dyspnea, very, very common symptom. Very common symptom. And what you have to do, you know. And fatigue also, approximately 40% of cancer patients and COPD patients and anorexia, cachexia also there. So there are many things. Suffering at the end of life is universal. Please remember, you and me also included to this world, so it is universal. Has no social, religious, geographical boundaries. Life-threatening, incurable disease does not respect your age, wealth or social standing. Please remember those things. And end of life care, the only guarantee, there is a guarantee. So only guarantee for comfort in suffering at the end of life is meaningful relationships. When you are living now, at the moment we are living, but you have to live meaningfully. So these are the take-home message. Thank you so much. We have 2 minutes. If there are any questions, I can answer. This recording will be yours. If you want the presentation, I can email. And please make use of it. Thank you.
Thank you very much for the very valuable presentation, sir. It's very informative, and thank you for your kind sharing this lecture with us. Thank you very much. Thank you, sir.
Any questions?
Thank you very much, sir.
No questions. Have you ever come across patients like with end of life care in your practices?
Yes, sir.
Yeah, because as general practitioners, as community leaders, you can do a marvelous job at your place. Because number one is people around you, they respect you. They hear you. They respect what you say. With the proper knowledge, you can handle, you can manage very nicely because you are available in your areas. So you will be a leader of the medical professional in your area. So with this knowledge, you can do wonders and ease the suffering of our people, our own people, and help them, not only the patient, for the family members also. And it is very meritorial thing. It's very meritorial thing. Thank you. If there's no further questions, I will stop. Thank you, sir. Okay, thank you so much.
Thank you, sir.
Thank you, sir.